Welcome to Pulse and Pressors, where critical care gets crystal clear. Acute respiratory distress syndrome is often approached as a lung disease, but severe cases frequently become a cardiopulmonary failure syndrome. The right ventricle is highly sensitive to increases in pulmonary vascular resistance caused by hypoxia, hypercapnia, acidosis, and high airway pressures. As RVPA coupling fails, forward flow drops and shock can develop even when oxygen saturation appears acceptable. A normal SpO2 does not guarantee perfusion. ProtekDuo drains venous blood before it reaches the right ventricle and returns oxygenated blood directly into the pulmonary artery. This unloads the RV while also supporting oxygenation and carbon dioxide removal when connected to an oxygenator. It is a combined lung and right heart support strategy. However, it does not directly support the left ventricle. With ProtekDuo, position determines performance. The ideal tip is in the main pulmonary artery, and the cannula should follow a smooth S-shaped path. Small depth changes can significantly affect flow and support. In sudden instability, position should be checked immediately. Functional clues such as waveform and flow behavior may reveal problems faster than static imaging alone. This configuration creates a different mixing physiology than standard VV ECMO. Because oxygenated blood returns into the pulmonary artery, blood in that circuit is strongly influenced by ECMO flow. Interpretation of venous saturation therefore changes. If oxygen saturation remains low despite good circuit numbers, think beyond the machine. Shunt physiology or an unfavorable ECMO flow to cardiac output ratio may be the real issue. Management can be simplified into 4 control variables. Sweep gas primarily controls carbon dioxide removal. Flow is a major driver of oxygen delivery. ECMO FiO2 determines oxygen content. The ventilator's role becomes lung protection with rest setting if the patient needs ventilator support. Ensure plateau pressures under 25. In hypoxemia, ask whether supported flow is sufficient relative to the patient's total cardiac output and metabolic demand. Most ECMO bedside emergencies follow recognizable patterns. For hypoxemia, first assess position and flow, because these are common reversible causes. Increase flow if possible, then adjust ECMO oxygen fraction, while also evaluating for shunt, pneumothorax, or secretion burden. Hypercapnia is usually a sweep issue. Low flow should trigger rapid assessment for low preload, suction, obstruction, migration, or tamponade. More than one problem may be present at the same time. The circuit often tells you what is wrong before the patient does. Chatter or vibration usually points to a drainage side problem, such as inadequate preload or inflow limitation. High return pressures suggest an outflow problem, such as wedging, kinking, or obstruction. Distinguishing inflow from outflow failure quickly can save valuable time. 2 major cardiac failure patterns matter most. First, persistent right ventricular failure despite support presents with rising CVP, falling blood pressure, and worsening lactate. Second, left ventricular limitation may emerge after RV unloading. Increased venous return can overwhelm a weak or stiff LV, causing pulmonary edema and worsening oxygenation. Improving one ventricle can expose weakness in the other. Flow is never unlimited. It depends on venous return, preload, patient physiology, and cannula position. Increasing RPM without improving these constraints may not change delivered support. When pump speed rises but performance does not, think preload limitation, suction effects, or positional issues, rather than assuming the pump itself is failing. Weaning should follow recovery, not routine timing. Sweep is usually reduced first once carbon dioxide control is stable, followed by ECMO FiO2, and then cautious flow reduction with echocardiographic assessment of RV recovery. If the patient remains unstable, despite appropriate positioning and adequate support, the clinician must reconsider the physiology. If the numbers do not match the patient, rethink the model. This is Pulse and Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.